Okay, you have a patient who is complaining of shortness of breath, labored breathing, say 24 respiratory rate a minute, and able to speak in complete sentences. Take your oxygen bottle, make sure it's oxygen, because it's green, because it says oxygen, and it has the correct 3-pin index system there. You got your regulator, you have your gasket in there, you also have your 3-pin index system. Give it a quick there to blow out any impurities or dust. Line up your pin indexing system. Make it nice and snug. Turn your bottle on. Brand new bottles should have at least 2,000 psi. If you're going to give a nasal cannula, 1 to 6 liters per minute into the nose, around the ears, and then you cinch it up in the bottom. Obviously, I don't have ears, so it won't stay. For a non-rebreather, 10 to 15 liters per minute. You start by plugging it in, turning it on, covering up the mask hole, and then your bag will inflate. And when it's done inflating, take it off, put it on your patient. Cinch up the side straps, secure the nose piece, and then continue to monitor your patient and check on their breathing status. Okay, your patient has now become unresponsive. This one has no gag reflex, but there is a pulse. So take your mask off and pick the appropriate size oral pharyngeal airway. Remember measuring from the corner of the jaw to the corner of the mouth, and you can use either the tip down there. When you put this in, cross finger technique. Remember on the adult, it goes in backwards and then you rotate it 180 degrees. If you're using a kiddo or an infant, make sure to use your tongue depressor when putting it in. Remember, if your patient is conscious and alert or semi-conscious and has a gag reflex, you can use your nasal pharyngeal airway, measured from the nostril to the jaw line down here. Lube it up, and remember it's got that bevel in it. Bevel goes towards the septum. Okay, you're a sole responder. You're the only person there right now. You need to ventilate your patient. So the preferred method is the pocket mask with one person. So take it out, unfold it. You need a one-way valve. If your mask takes supplemental oxygen, it'll hook up to the end here. Remember, this is intended primarily for one person. You create your seal, you tilt the head back, and you ventilate. You ventilate using American Heart Association guidelines, 1 every 5 to 6 seconds, looking for chest rise, allowing the chest to fall down between each breath. And that is for the pocket mask. Okay, now you're ventilating and you see secretions and gurgling coming from the oral pharynx, so we have to suction our patient. We're going to use this suction device here, take it all apart. We're going to adapt our suction to the canister, and we're going to measure this from the corner of the mouth to the earlobe to determine how far in the suction is going to go. So we do that. Just secure a spot on there. Remember, when you're inserting this, do not lose sight of the tip. Okay, I'm going to turn on my suction to full suction power. And I'll turn it off so you can hear. Remember, on this device, you have to cover up that spot with your thumb in order to get suction. You can remove the OPA if you want. You create suction. You go in, sucking 15 seconds max. Suction only on the way out, not on the way in. And then you stop suctioning, and then you continue to ventilate your patient again. Okay, your partner shows back up with the bag valve mask. They usually come compacted, so you gotta, first step is to open it up, pull it apart, make sure you have your reservoir bag. We're gonna hook this up to oxygen at 15 liters per minute. And we're going to want to see that the bag inflates here at the end, which it is right now. We have our oral pharyngeal in. Remember, this is a two-person skill. One person will do nothing more than hold the seal and hold the jaw open. The other person will ventilate. Realistically, you will end up doing this as a one-person skill. One hand to seal and hold the jaw back, the other to ventilate. And we are looking for chest rise, according to American Heart Guidelines, once every 5 to 6 seconds. And we want to watch the chest rise and fall. If you don't see any chest rise, check your seal, check that you have the head in the right position, check your oral pharyngeal airway, that it's appropriately sized. Okay, the next step that's happening is your patient is continually not breathing, so we need to put in a definitive airway or the blind insertion. Patient has a pulse. We're not going to do CPR. We're going to start with the king. So remember 3, 4, 5. If you ever forget, it's always stamped on here. So I chose the size 4 because my mannequin is 5 foot 5 inches tall. My partner is ventilating the patient. Right now, I'm going to test fill it up to 70 cc's. I'm going to check my pilot. My pilot fills okay. I don't need to depress down here my balloons. I'm going to take the air out fully. I'm going to reset my syringe to 70 cc's air. I'm going to lube this up. Lots of lube is good. I have all the equipment I need. I have my stethoscope. I have my security device. And I have my end tidal capnography. When I tell my partner to stop and remove the oral pharyngeal airway, I put the head in a neutral inline position. Thumb holds the tongue and lifts up the jaw. I come in from the side and I go midline and I depress until the teeth rest on the red block right there. First step is to insert about 60 cc's of my air. Bag immediately. I should expect to get resistance, which I do. I pull back and ventilate until I see chest rise, and I have lost all that resistance so I can ventilate easily. At this time, I would put in 10 to 15 additional cc's of air, and I would ventilate again. I see chest rise. I don't have any problem ventilating with the bag. At this point, I would have my partner ventilate for me. I would check lung sounds, expecting to hear sounds in the lungs. I would not expect to hear sounds in the stomach. I would attach my capnography device, turn that on with the monitor, continue to monitor that. The last step is I would have my partner continue to ventilate. I would put on my commercial grade tube holder device, cinch it up, strap it up, and secure it in. And that's it. Okay, so if I'm going to suction the gastric contents of this with this device here, okay, I'm going to suction with my king using the gastric decompression. Remember, the measurement is the corner of the lips, roughly to the ear tip, and then down to the xiphoid process. I'm going to mark that spot. As my partner is ventilating, I'm going to take that spot and put it down the back of the tube, all the way down until I reach that spot that I marked with my hands. This end of it will hook up to my suction device, and this is where you would adjust the suction to the low setting on your suction to do the gastric decompression. If I was going to suction, if I saw fluid and blood coming out of the tube, I would simply take my suction device, there's a couple of them, hook it up to your onboard suction, remove the bag valve mask, put that suction tube down the king tube until you meet resistance. initiate your suction, twizzle out, no more than 15 seconds, and once you remove that, immediately continue ventilations. Okay, oral airways in, patient has a pulse, I'm ventilating for my patient, I'm going to stick in the combi tube, my partner is going to take over ventilating for me while I get my equipment set. So I'm going to take number 1 lumen, it says 100 cc's of air on there, fill it up to 100 cc's of air, take my syringe off immediately. Number 2 tube is the white one for 15 cc's of air, fill it up, take off the syringe immediately. I'm going to check both my pilots to make sure that they hold air, and then I'm going to remove the air from the syringe, or from the combi tube. Removing my syringes. I'm going to set my syringes at 15 and 100. I'm going to lube the distal tip of my combi tube. At the next breath, I'm going to tell my partner to stop breathing, take out the oral airway, put the head in a neutral, inline position, lift up the jaw and the tongue. I'm going to center line this immediately, depressing it down. I have 2 black lines here. That's my spot indicator. Put that on the gum or the teeth line. And blue lumen number 1 is 100 cc's of air. Put that in immediately, taking the syringe off. White is number 2, 15 cc's of air. Put it in, immediately take off the syringe. I'm going to ventilate out of lumen number 1. I would expect to see chest rise, which I do. So I'm going to have my partner ventilate. While they ventilate, I'm going to listen for lung sounds in 4 spots. I'm going to hear, and I'm going to listen for stomach sounds and hopefully not hear them. If I was to hear stomach sounds with lumen number 1 and no chest rise, I would simply switch bagging to lumen number 2, and I would expect to see chest rise and no stomach sounds. I don't need to secure this device with anything, but I do need to put capnography on whichever tube I'm going to ventilate through. And the same principles of suctioning. If I need to suction the trachea or blood, I do it through that lumen. If I need to suction or decompress the stomach, I do it through lumen number 2, because the port for that lumen opens up into the esophagus, and that's where the stomach contents would come out. The last device is the eye gel. So again, oral airways in, patient has a pulse, it's not trauma. I'm ventilating, and I need to stick in an advanced, or the blind insertion airway. So my partner's continuing to ventilate. I'm going to choose my eye gel based on the weight of the patient. So size 5 is 90 plus kilos, so over 180 pounds. Take it off. Again, lube is your friend, so there's that port for lube. Put some lube in there. You want to lube the back side of this. So after a ventilation, tell my partner to remove the oral airway. I put the head in a neutral inline position, and I insert my eye gel following the curvature of the airway. Now you put it in until I meet resistance, and then I immediately start bagging, and I would expect to see chest rise at this time. After I see chest rise, I listen for lung sounds, and I listen for the absence of stomach sounds. I feel confident with that. I would attach my capnography, hook that up to the monitor, continue to ventilate the patient. American Heart Standards, now that we're doing this, we can do 1 every 6 seconds. If we were doing CPR, we could do it 1 every 6 to 8. If I wanted to suction on this device, same principles. I can suction down the port right here to suck any blood or fluids out. If I wanted to decompress and suction out the gastric contents, remember there's a port here, and I would simply measure my device from the jaw, or the lips to the ear lobe to the xiphoid process, and then I would insert that here, and that tip comes out the end, and that will go into the esophagus and then into the stomach and empty out the gastric contents. And again, that is the last thing you have to do with that is hook it up to your suction and turn it on low suction. To secure the eye gel once it's in place, you could use some tape, wrap it around the device, wrap it around the jaw, and then just continue to ventilate, watching for chest rise and fall, and continue to assess your patient.